Great. So good evening once again. Welcome to our lecture series on good evening once again and welcome to our lecture series on the renal system, and the topic we would be handling on the renal system. Of course, it doesn't mean that we've handled all topics related to nephrology. There are still a host of topics there, but then in terms of your practice now, these topics that we've done in the past and what we're going to do today is what is going to help and going to give you the basis of understanding other cases of nephrology once they come to you, because you realize that most of the other cases that you are going to come across in terms of nephrology would usually probably follow a pattern of what we've discussed. Probably there's an infection somewhere, or probably there's a condition which eventually might lead to some form of kidney damage and then kidney failure, or probably there's a condition which would result in maybe an abrupt distortion in the function of the kidney, and then later this function picks up. So basically, these topics that we've treated and what we are going to do today is just supposed to act as a foundation, and based on your physiology, your renal physiology that you did in the past, and adding this other clinical aspect to it. The pathologies we've discussed here and the clinical aspects and investigations and all that, management protocols, adding that to it, you should be good when you come into contact with any case. You should be able to, of course, make the proper investigations or institute the proper investigations, and then also institute the proper management protocols. Okay. So today we are talking about chronic kidney disease. This is the lecture outline. At the end of the lecture, I would want you to know what chronic diseases, chronic kidney diseases, and usually once we say someone has a chronic kidney disease, or along the lecture, I'll be using CKD a lot, and someone has a CKD, what that means. Some literature will also say CRF, which is a chronic renal failure. For the purpose of this lecture, we'll be using CKD, chronic kidney disease. Okay, so what does it really mean? We'll look at some risk factors. We'll look at, in terms of etiology, what would lead to a patient developing a CKD. We'll also talk about how it comes about, the whole pathophysiology behind it. Then, of course, we touch on clinical features. We look at complications, how you would be able to investigate your patient, and then what you do in terms of management. As I always say, these slides are simplified and summarized, but then at the same time gives you a broad view of what is expected. Once you're able to go through the slides, you can always go on to the net, download documents that are related to the topics that we've done, and then just read a little bit more to just expand your knowledge, because knowledge is rapidly evolving. So it's actually good. You always try to build on that. Okay. So let's look at what chronic kidney disease is. And usually when we talk about chronic kidney disease, what we are trying to say, the word chronic there is telling us that it's a long-standing condition. Okay, this is a long-standing condition, and basically what is happening is that this long-standing condition would basically lead to a progressive impairment in the renal function. So it's not like you have a long-standing condition where your renal function is probably reduced to, let's say you started with 40 and we are saying long standing, and in 6 years, maybe we are saying 40 is reduced. So probably by calculation, your renal function starts at a value of 40. In 6 years' time, it still remains at 40. No. Usually in chronic kidney disease or in CKD, the renal function would progressively reduce over time. And the pace at which this renal function reduces is dependent on how the patient is managed. If you are able to pick up the condition early and then you are able to institute proper management, there'll still be the progressive impairment in renal function, but then this is going to be at a slower pace. Whilst if you have risk factors which are basically uncontrolled and leads to, this risk factors that you have, the values keep going up, then definitely your progression is going to be accelerated and you are going to have a progressive impairment or a rapidly progressive impairment in the renal function. Okay, so comparing this definition to what we said in our lecture before this one, in terms of impairment of renal function, we said that acute kidney injury or AKI or acute renal failure would usually give you an abrupt, okay, so it just stops. It gives you an abrupt impairment of the renal function. And usually, most of the time, we said that over 90% of the time, it tends to be reversible when you are looking at acute kidney injury or acute renal failure. But in chronic kidney disease, it is not abrupt. It is very slow, at a slower pace, okay? If you are controlling the risk factors and all those things that are affecting it. If you're controlling it, then it's at a slower pace. If not, then it's still progressive, but at an accelerated pace, okay? But then you can't reverse it. Once you make a diagnosis of chronic kidney disease, and let's say your patient's value for making the diagnosis is probably 40, then you can't get it coming back again or coming up in some years' time. It would only decline over time. So that is the difference between a chronic kidney disease and acute kidney injury. Whereas an acute kidney injury can just happen abruptly and just kill you there and then because of the abrupt depression of the kidney's function. Prognosis is good when we pick it up early, and most of the time recovery is good. But once you have a chronic kidney disease, you know that definitely with time, your values will be dropping down, and you can't get it back. And all you can do is just to slow the pace. If you slow the pace, then it means there's a lot of time. If you don't slow the pace, then it means that you'll be singing Do Me Nearer Today faster than the other person whose pace is slower. So how do we define this? It's not enough to just say it's a long-standing progressive impairment in renal function. How would you know that there's an impairment in renal function? So there is a limit, given a parameter, okay, that we base our assessment on, and this parameter is what we call the estimated glomerular filtration rate, or the eGFR. So most of the time when you request for your BE and creatinine and then the results comes, you'll see that after they've given you your electrolytes and they've given you your value of the urea and the creatinine, they put capital G, capital F, capital R. This is what we call the estimated glomerular filtration rate. And this eGFR is very essential because the value that you get there is what points us to the diagnosis, or is what helps us in making a diagnosis of a renal impairment, okay? So once you have a patient who has an eGFR of less than 60 mils per minute per 1.73 per meter squared, this 1.73 per meter squared is like the surface area. So it's just a uniform calculation. Once you have EGFR less than 60, then you can actually go ahead and say that the patient goes beyond this less than 60 persists for more than 3 months, then you can say the patient has a chronic kidney disease. When we were touching on acute kidney injury, you remember we had a criteria which we described as a Rifles criteria, where you have the risk, injury, failure, loss, and an end-stage renal disease or end-stage kidney disease. And you remember with the Rifle criteria, the E, which is the end-stage kidney disease, we said that usually the acute kidney injury persists for more than 3 months, and then you can say the patient has gone into an end-stage kidney disease. So that 3 months value here is very key for us. If we should see a patient and then we should do a BE and creatinine with EGFR for the patient, and then we realize that, oh, your EGFR is below 60, most of the time you shouldn't be in a haste to make the diagnosis of a chronic kidney disease, especially if it's the very first value you are getting for this patient. If probably this patient comes to the hypertensive clinic or the diabetic clinic regularly, and then patients would usually do a 3 to 6 months BE and creatinine and all that during review. So you have records, okay? And then probably the last 3 months the patient came, probably EGFR was around 60, and this time EGFR is around 40, then it's alarming because you have a 3 months value and then the EGFR has dropped. So you can be thinking this is a chronic kidney disease, and it won't be so surprising because we know hypertension and diabetes, as we go on, you realize that one of the, there are some of the factors that will lead to you developing a chronic kidney disease. So repeating your test is very essential. And also once you are suspecting, especially when your EGFR is low, doing further investigation to look at the state of the kidney is very essential, which we'll be talking about in a bit. I'm saying this because I recently saw a patient who has some form of arthritis. So she's been managed, they're giving a lot of analgesia. We are giving her a lot of NSAIDs, and also her uric acid was a bit high. So they said she had gout, they put her on allopurinol. And basically what happens is that this medication tends to have an effect on the kidney. So initially her EGFR, because I'm usually privy to seeing her labs, her EGFR wasn't below 60. But she starts taking NSAIDs and all those other medications, and then EGFR drops rapidly to about 40. And this, wasn't even in 3 months, like it was so fast. Once you see something like that, you are prompted and you think, okay, what is happening here? Okay. And a patient like this, who also has hypertension and all that, you are thinking, okay, could this be a chronic kidney disease, which is so rapid? But then you should be careful when you're making such a diagnosis, because even though a patient has risk factors like hypertension, and this could be a chronic kidney disease, if the patient should go off the medication, and then you should do serial repeats of your kidney function test and EGFR, you realize that the EGFR will start going up steadily. So it means what this patient had, if probably the patient had some sort of chronic kidney disease in the background, the drastic fall or the rapidly progressing drop in the EGFR was probably due to the NSAID medication. Okay, so in that case, you say that, okay, so the patients, even though there's some background of chronic kidney disease, what caused the rapid acceleration was the NSAID, and that was an abrupt or an acute thing. So the patient was experiencing some form of acute on chronic kidney disease. Okay, so I'm chipping that in because you know about acute kidney injury. Now you know the definition for chronic kidney disease, but you could have circumstances where you have a patient who probably has risk factors for chronic kidney disease, and maybe EGFR is just a little bit below 60, maybe 58. And in a very short space of time, you realize EGFR is dropping so fast. Okay, so that could spur you on to thinking about something else, because why is it dropping so fast? This is because probably the patient is on something else, maybe herbal medication, maybe some drugs, NSAIDs, all that, or maybe the blood pressure has now accelerated. So then that becomes an acute on chronic kidney disease. Okay. So now that we know how to define CKD and we are saying EGFR less than 60 mL per minute, let's look at the risk factors. So what will predispose someone to developing a chronic kidney disease? And as you can see, the first thing is the black race. We are gifted in so many ways and all that, but when it comes to some of these illnesses, we tend to get them faster, or we are more susceptible to them than the other race. Okay, so that should also guide you when you're advising your client. And for me, whenever I'm seeing my patients, especially the hypertensive and the diabetics, one of the things that I hit on to make it sink in is the fact that we are Blacks and we are predisposed to a lot of the complications that arise from these two major chronic conditions. Okay, so when you read literature, you see other complications, heart diseases, strokes, and all that. So you always need to let it sink in, let your patients know that, I'm of a Black origin and I'm at risk, so I need to take good care of myself. Okay. Age. So risk factors include, once you are aging, the risk that your kidney function would be depressed is also, high, especially when you are aging and you are Black, and then you have other risk factors like smoking and all that. Then it means that you also even be depressed at a faster rate than the general population. Diabetes, hypertension, we've talked about that. Some drugs tend to have a toxic effect on the kidneys, what we call nephrotoxic drugs. So you can see some antibiotics like gentamicin or the aminoglycosides, they tend to be nephrotoxic. Your NSAIDs, contrast media, herbal medications, all of these things. So you just need to counsel your patient on that. So etiology, what causes CKD? There are so many conditions that can lead to a chronic kidney disease, so many. Okay, so looking at this lecture, we try to basically categorize them under, different themes. So you're looking at the congenital causes. So some people are born with conditions that will predispose them to developing a chronic kidney disease. So you can see that in this patient, they tend to develop it at a very young age. Okay, so if people who have polycystic kidney disease, people who have what we call medullary cystic disease. So you can see that this disease is presents with some form of cysts, cystic lesions in the kidneys. So tuberous sclerosis, congenital obstructive uropathy. Some people are born with obstruction of their urinary tract system. Okay, so some males are born with a condition called a post-urethral valve. Okay, they have some valve sitting there, and then it tends to obstruct the urethra. It tends to obstruct urine outflow. So urine is unable to come out. It stays there, and then once you have an obstruction, you have fluid building up in your urinary tract system, and then it can go all the way up, and then it can affect the kidneys, okay, which we've talked about in our previous lecture. Then you can have diseases of the glomerulus, which we've been talking about for some time now. And so you can have a glomerulosclerosis, if you go like some poor perfusion to the parts of the glomerulus where it leads to maybe destruction of the glomerulus. You could have diabetes, sometimes BP goes up, what we call accelerated hypertension, sickle cell disease. All of this would lead to a glomerular disease. Vascular diseases. So sometimes you can have some sort of stenosis of the vessels supplying the kidneys, like a renovascular disease, and this can actually cause the kidney to fail. You can have inflammation of the lining of or the endothelium of your vessels supplying the kidneys, or called vasculitis. Sometimes you can have a nephrosclerosis that can lead to hypertension. And then tubulointerstitial disease, like you have a disease which is affecting the renal tubules, okay, so proximal convoluted tubules and all that. And you know the functions that this plays is very essential because it's supposed to reabsorb some of the good things that have escaped the glomerulus. It's supposed to reabsorb that back into circulation. If you have a disease impairing this, then it means reabsorption becomes impaired, and then you tend to lose some important substances that the kidney needs. So for instance, if you're exposed to certain drugs, nephrotoxic drugs, you have conditions like multiple myeloma and all that, then you can actually develop a CKD. If you have an obstruction along any part of the urinary tract system, like you have a stone, the prostate is big in males, you have a pelvic tumor, which is compressing the ureters or compressing other aspects of the urinary tract system, all of these would predispose you to you being unable to get rid of the urine. It stays in there, built up, gets into the kidneys, and then of course, you know the end effect, because you're going to have hydronephrosis, and eventually this hydronephrosis is going to affect your kidneys function when it persists for a very long time. So let's look at the pathophysiology. So how does this happen? Now we know what causes what. Now let's look at how it happens. Okay. So basically, the kidney is exposed to any of these conditions that we talked about, we mentioned just before coming here. And once you have these conditions coming in, what it does is that it leads to a destruction of the nephrons. And you know the nephrons are like the basic units there in the kidneys. So what we talked about will lead to a destruction of the basic unit of the kidney, which is the nephron, okay? But once it starts getting destroyed, of course, you know that the body is always able to go into a compensatory state. So your body would start making the rest of these nephrons present, which are not affected, your body would start making them bigger. Okay, so there's what we call a compensatory hypertrophy. So the nephrons that haven't been destroyed yet, the body would cause them to become hypertrophied so that they can be able to filter more. Okay, so there's hypertrophy and then hyperfiltration, okay, through compensatory mechanisms. So once the remaining healthy nephrons undergo this compensatory phase and they become big and then they are filtering more, it comes in to get rid of the waste substances. So we don't really feel the effect of the kidney failure at that point. Okay, but what happens is that you now have reduced numbers of nephrons. However, the pressure of the pressure gradient of the blood coming to the Bowman's capsule and then the glomerulus for filtration hasn't reduced at all. It's basically the same pressure. Okay, so now you have few glomeruli being exposed to this pressure, and this pressure would be increased basically. Okay, so the increased glomerular pressure would eventually lead to destruction of the okay. So usually you don't really feel any, basically you don't feel any effect at all, okay, until the nephrons, you have more than 50% of the nephrons being destroyed, okay, then we start having a measurable increase of the serum urea and then creatinine, okay. So once you get to investigations, you realize that even though a BE and creatinine is very good and is essential in making a diagnosis of a chronic kidney disease, if you want to catch a kidney which is failing at an early stage, if you want to catch it faster, you want to catch it at an earlier phase, your BE and creatinine is not your go-to, because before your BE and creatinine will start elevating, you would have lost about 50% of your nephrons, okay, before you're going to recognize any change in the system. All right, so this table here basically takes us through the classification or the grouping or the staging of chronic kidney disease. It's classified into 5 major stages. Okay, Dan, your hand is raised. Let's take a question.
Please, the loss of the 50%, is it only in one kidney or both? Hello, Doc.
Hello, Dan. Can you come again, please?
Yeah, I wanted to know about the 50% loss in the kidney function. Is it only in one of the kidneys or both?
In both of the
because I was thinking
right,
maybe
great.
if one is completely shattered.
Yes, so that's a good question.
One.
So so the 50% figure we are using here in terms of this lecture is the general theme. And as a person, unless you've had one of your kidneys surgically removed, or you've been told that one kidney is not working, but the 50% is calculated based on both kidneys at that point. You understand?
Yes, sir. Thank you, sir.
So you're welcome. So that's what we are. That's what we are looking at. So if the patient has only one kidney, then it means that this patient is going to show symptoms faster than the other patient who has got 2 kidneys, because your 50% will just be calculated based on 1 kidney. You understand? Are you okay, please?
Yes, sir. Okay.
All right.
Okay. Yes, Doc. Yeah, so what I want to get, if assuming you lose a full or one kidney completely, will you be able to survive or live a normal life with the one surviving?
Yes, you would. You'll be fine. You'll be okay. You just have to make sure that that one that is surviving will be protected, because then when you are exposed to any of these risk factors that we mentioned, that we're saying can lead to a chronic kidney disease, you would end up showing symptoms faster, because your 50% is now going to be assessed based on just that kidney. But then ideally, you should be able to survive on just one kidney, okay? Are you okay?
Yes, Doc. I'm okay.
All right, great.
Yeah, Doc.
Yes, please.
Yeah, I'm looking at, I leave a question in the chat box for you. I want to find out whether the Blacks as a race for this CKD has something to do with the melanin.
All right, okay. I would have to read more. I would have to read more about that. But just like the same way Blacks have a lot of risk to certain cardiovascular disease, and then you can see that in terms of CKD2, there's a cardiovascular relation I am looking at it towards that direction. I don't know if any studies have been done to relate it to the melanin. It will be interesting. After here, I'll take a look at it and see if they've done any studies to relate it to the melanin and why would the melanin predispose then to developing a CKD. But when you look at the same reasons why we are more at risk of cardiac disease, strokes, and all, you can see there's a vascular thing over there. Okay, and this could probably be due to, some special changes in our vascular system, or it could also be due to the fact that, global population looking at dieting and all that, because our diet and then our lifestyle practices, the obesity and all that is increasing, and we have more atherosclerosis and all that. That could actually be the reason, one of the reasons why we are having a lot of risk when it comes to vascular conditions. But with melanin, I would have to take a look at it and see. Okay, it will be very interesting. But you can share if you've come across any studies of that sort. Okay.
Okay, Tom. Thank you very much.
You're welcome. So yes, so let's look at our table. So usually there are 5 stages, stage 1 to stage 5. And yes, obviously stage 5 would mean that the condition is more severe than the other stages below. And we assess the stages based on the EGFR. So usually once we say a patient has stage 1 chronic kidney disease, most of the time their EGFR is more than 90. But you see, when you look at our definition for CKD, we said that the drop of EGFR starts below 60. So why are we putting above 60 in there and all that? So if you look at the very last bit under the stage 5, you can see that I put a statement there that when the EGFR is more than 60 mils per minute, so in the stage 1, which is more than 90, and then in the stage 2, all those above 60 mils per minute. When the EGFR is more than 60 mils per minute alone, okay.
Who is that? Why are we at the total station?
So when the EGFR is more than 60 mils, that alone wouldn't mean the patient has a CKD, because that even goes against the definition that we gave in the initial phase. But if the EGFR is more than 60 and this patient has some other evidence of kidney damage, maybe you've done a scan and you've seen some evidence of kidney damage, okay, then you can go ahead and then you put the patient in that stage. But once the EGFR is below 60, you don't need any form of evidence of damage to tell you the patient has a CKD. The evidence of damage or the scan might just direct you and tell you, what is happening and what not, okay? But above 60, you need evidence of damage to say the patient has a CKD, because with the definition, or per the definition, the cutoff was 60 mils per minute. So you can see the stage and you can see the EGFRs attached to it. You can try and memorize it. It's good if you know, and you are discussing a case with your colleague or your boss or the consultant, and then you can say, oh, this patient has CKD stage 3B. Then it's nice. It's like, hey, wow, you know what you're talking about. You want to say that the EGFR is between 30 to 44. Everybody's happy that you know. Okay, you can see, oh, this patient has an end-stage renal disease, and you want to mean that the EGFR is now below 15. Okay, so it's good you know these things. Clinical features. So once a patient has a chronic kidney disease, usually, yes, Glover, I'll take your question in a bit. So usually about from the first stage to about the third stage, they tend to be asymptomatic. They don't really show much features, because by then you don't have enough urea and creatinine level building up in the blood to cause features. And then by then the kidney is still able to retain some excretory function. So it's getting rid of some of the fluids and all that. So you don't have the edema and all that. But in advanced cases, once you go beyond stage 3, then the waste substances will start building up because the kidney's function is basically compromised now. So the symptoms that you basically develop when you have a CKD is secondary to the buildup of waste substances, nitrogenous waste like urea, buildup of quinine, the inability to get rid of fluid, so you have some form of edema and all that. So you can see that advanced cases will present with loss of appetite, general body pains, lack of sleep, itching, the mind becomes slow, you have seizures. All of this is secondary to increased urea levels, or what we call uremia. Okay, all of this is increased, is secondary to the uremia. Also, you can realize that the patients, we're saying that, I mean, they would urinate frequently, they have an nocturia, they're urinating, they're producing large volumes of urine and polyuria. The question is, if the kidney is failing and is unable to get rid of waste substances, why are they urinating frequently? And usually that's what happens. Once the kidney is failing in the initial phase, you end up urinating a lot in large volumes. Why? Because you remember what we said about the tubules and its function to reabsorb. Once you are losing the function of the tubules and then the cells in the tubules and they are unable to reabsorb, then you are going to have the urine that has been filtered by the glomerulus, even if that's little, would come out and the person will be producing large volumes of urine because the reabsorption function of the tubules have also been compromised. So this will happen, and then with time, when the glomerulus is unable to filter anything at all, then the urine output will start dropping. Okay, so don't be too surprised and say, oh, the patient has a chronic kidney disease, so why is the patient urinating in large volumes? Okay, that could tell you that that's the initial phase of the chronic kidney disease, and it's because there's still some EGFR, there's still some glomerular filtration going on, but then there's a loss of the ability for reabsorption in terms of looking at the tubules. There's a loss of the tubules' ability to reabsorb, and hence the patient would end up peeing in large volumes than before. You can see general pruritus there, which means itching, and that is because of the urea. The urea causes a lot of things. So you can see they tend to have a peripheral edema or pulmonary edema. It gets to that point where they are unable to get the urine out. So of course, the fluid retention and also sodium retention, it makes it worse. And then they have the edema. And then the edema can be peripheral or they can have a pulmonary edema. Nausea, vomiting, diarrhea is because of your urea levels. They also tend to have symptoms of anemia. And as you can see, the kidney is responsible for producing a hormone called erythropoietin. And this erythropoietin is essential in stimulating the bone marrow in making your red blood cells. So once the patient has a chronic kidney disease, one of the main features that you will see usually is that they'll come to you with a low HB, okay? And another reason why they'll have a low HB is because the urea can cause them to bleed. So they can have hemorrhage secondary to the uremia. So they can have a uremic gastritis. So they have an inflammation of the stomach lining and they'll be bleeding because of the urea levels, okay? So because of the electrolytes imbalance and then a decreased calcium levels and secondary to an increased phosphate levels, they would have paresthesias and all that. Then they have what we call a restless leg syndrome, also because of this whole electrolyte issues. Then they have hormonal problems. So in females, menses can actually stop. In males, they will tend to develop erectile dysfunction. They sometimes have a bone pain, and this bone pain, we call it renal osteodystrophy or a dynamic bone disease. And the reason being that usually once the kidney starts failing, phosphate levels will build up in the blood. So you have hyperphosphatemia, and once you have increased phosphate levels, the opposite happens for calcium levels. You are going to have hypocalcemia. Now your body would have to replace the calcium. So your body would cause the production of what we call the parathyroid hormone. And this parathyroid hormone will basically come in and cause resorption of the bone in a bid to increase your calcium level in the blood. Once it causes resorption of the bone, will lead to the bones becoming weak, and then you tend to have bone pain and all that, what we call renal osteodystrophy. So before we get to complications, I'll take the question. There was a hand up. I'll take it quickly and then we move to complications.
Please, I would like to ask, yes, please, looking at the CKD, the staging, I quite remember my board said something that we also have stage 0, which the GFR is greater than 90, but the person has comorbidities like DM and HTN and others. So what about that one also? I would like to ask.
Okay. So if you try and go on the internet, you read documents that have been accepted, because in medicine now we call it evidence-based. Okay. And it's there because people come up with all sorts of funny things based on how they feel and all that, but you can't come up with things based on how you feel. Sometimes it has to be supported with documentation. I'm yet to see a stage 0. I know that people try to chip that in because they want to hit it at the back of the patient's mind that, hey, you have risk factors, so be careful. Otherwise, you would end up developing a chronic kidney disease. But when you look at the staging, it's not an accepted thing in terms of documentation. It starts from stage 1. Okay.
Okay.
So it starts from stage 1. If anything, that could be a pre-CKD stage or a risk stage. But then we don't classify that as part of the stages of CKD. Because if you are saying stage 0, you are saying as part of the stage, it means you want to say the patient has CKD, some form of CKD, but then the 0 there wouldn't really make sense. You are saying stage 0, but then you are trying to also explain that, oh, this patient doesn't have CKD, but the patient has risk factors. So you just say that that's the risk stage, but then you don't say it's part of the stages of CKD. Okay. Are we okay?
Yeah, no.
Okay, yeah, I'm sure we are good. Yes, I'll take the other question and then we'll go on.
Yes, Doc, I'm looking at whether acute kidney disease can resolve to chronic kidney.
Yes, it can. Exactly, it can. And it was one of the things we talked about previous lecture before this one. We said when you look at the RIFLE criteria and you get to the last stage, you know, the RIFLE, there's risk, which is R, injury, which is I, failure, which is F, loss, which is L, and then end stage renal disease, where we say that the AKI or acute kidney injury persists more than 3 months. And you can see that with the definition of CKD, we are also using 3 months. Once you have an acute kidney injury and you go beyond 3 months, then you are being pushed to that area of a chronic kidney disease. So yes, acute kidney injuries can lead to a chronic kidney disease. And even during this lecture, I said that with acute kidney injuries, about 90% or more of them tend to recover. But then it tells you that the rest of them that don't recover would go on to developing a chronic kidney disease. Are you okay?
Yes, please. Thank you.
You're welcome. Excellent. So let's look at the complications first, and then we can move on. I talked about anemia, and I told you the reason why. So erythropoietin is decreased. There's bleeding because of the uremia. The whole urea also like it's basically toxic. So it affects the bone marrow. There's increased red blood cell destruction and all that. Renal osteodystrophy, I've explained to you already that there's increased phosphate levels, and this will lead to a decreased calcium level, and your body would have to find a way to replace calcium. So it calls on the parathyroid hormone, and this parathyroid hormone is responsible for causing calcium resorption from the bone, or it causes bone resorption. So it comes and it pulls out calcium from the bone. And once it pulls out calcium from the bones become weak, and then you can have conditions like osteomalacia, osteoporosis, osteosclerosis, a dynamic bone disease. Then there's skin disease, and basically this is due to the effect of the urea. You itch, the skin can sometimes become dry and all that. So they tend to have things like that. Then the uremia can also affect the pericardium of the heart and cause what we call a uremic pericarditis. In terms of gastrointestinal function, they can bleed because of the electrolyte imbalance. They can have a constipation. They can also develop a pancreatitis and a reflux esophagitis. Endocrine, we said it can affect your menstruation. You can actually become amenorrheic. In the males, it affects your testosterone. It can affect your fertility. It can also basically affect your erection as well. Okay. And you can see the other effects it has on thyroid hormones and then growth hormones. So it's a big thing. It's a whole systemic thing. Even though it starts from the kidney, the effects of the waste substances are, you can see that the nervous system also, it can cause coma, and it can affect the whole system. As I talked about, they can also have a restless leg syndrome. Sometimes they can become very depressed, they become psychotic. As part of the management, we do dialysis, and sometimes that could lead to forgetfulness, what we call dialysis dementia. In metabolic, it leads to increased uric acid deposits, so they can have gout, they can have their insulin, it becomes a little bit problematic. Okay, so they have a decreased insulin breakdown in excretion. So you should be careful if you have a diabetic who has a kidney disease, because they don't really get rid of the insulin easily. So you have to adjust their dose and reduce their dose. Otherwise, if they still stay on the same dose, you are going to have excess insulin accumulation, which is going to lead to hypoglycemia. So you need to be careful when you are dealing with that. And then also there's a impaired lipid excretion, so the lipid levels tend to build up. Nat, your hand was up, so let's take your question and then we move to the next section.
Okay, sir. Sir, with the complications, right? I quite remember I was reading something about this, and it was saying hypokalemia and heart conditions can cause. It was not that detailed about it. So I wanted to ask, is it true, and how does it cause it?
Yes, so I mean, it's all about the electrolyte imbalance we are talking about, okay? And you remember we talked about potassium metabolism, hypokalemia, how you manage when we're talking about the AKI. I don't know if you remember.
Hello, Doc.
Yes, hi.
Please, your voice is down. I don't know whether it is coming from me.
No, I think it's my mic. It does that sometimes. So
Okay.
let's just give it some time and then it will pick up. Sometimes it just goes down a bit. I don't know why. I think I need to get a lot of money and get a MacBook or something. So yeah, if you guys have any businesses that will make me rich so I can buy a MacBook, I'm interested.
See us back door.
Yes, sir. I'll see you back door. All right. So I don't know if you can hear me. Is it better now?
Yeah, it is better for me now.
you manage.
It's okay. Great. Yes. So in terms of potassium levels, now, as I said, similar to what we talked about in AKI, It's in the slide, so we try and go through. So once the kidney fails, right, the ability of the kidney getting rid of potassium would also be impaired. So potassium levels would build up, it would elevate, right? And we know that hyperkalemia can lead to cardiac arrhythmias and cardiac arrest. Hypokalemia can also do the same thing. So you need to be very careful. Once there's hyperkalemia, you have to manage, but you need to be careful you are not being overzealous or over managing your patients, which will also lead to hypokalemia, and that will also kill your patient. So I'm sure that is what you read there. The potassium levels, whether it goes above the upper limit of normal or below the lower limit of normal, has implications on the myocardium and can lead to cardiac arrest. And that's why even in the management of potassium, high potassium levels, we say you give 10 mils of 10% calcium gluconate to protect the myocardium. That's the reason. Okay, so it's in the slide, so kindly take a look at it, right? Are you okay?
Sir, please, I can't hear anything at all.
Yes, sir.
Okay. But could you
Yes,
hear me, or could you hear me?
Yeah.
Or you want me to take it again?
Yeah,
So we can hear.
All right. So did
The
you
other
hear the
you
bit
said, I
about
didn't
the
hear anything.
potassium?
No.
Corina.
All right.
So, sir, it means it is not only the acute kidney failure that we do the potassium, the gluconate injection.
No,
Can
not
do it
at
in
all.
chronic
It's
kidney
not.
failure as well.
Yes. So any condition, and not just chronic kidney failure, any condition that will lead to increased or excess potassium levels, you do, that's the management of hyperkalemia. You do that to manage. And if it is low, you'd administer potassium to let the potassium levels go up. But if it is high, you get rid of the potassium by doing your insulin, dextrose, and protecting the myocardium with your calcium gluconate. Okay.
Okay, sir. Just a follow-up question, sir.
Okay.
So, can this condition, can it also cause the decrease of the immunity that will make you vulnerable to any form of attacks?
Yes, so it can. It can also affect your immune system. Clearly, the immune system is a big word. In the immune system, you are not just looking at antibodies and whatnot. You are also looking at the protective layer and all that. And look at some of the effects of the high levels of urea. It's affecting the mucosa of membrane, peeling them off, exposing them. There's bleeding and all that. If you have any bacteria which finds itself somewhere, it can easily penetrate, get into the blood, and then cause an infection. Moreover, the edema would also provide a medium for microorganisms to grow, to fester, and then they can cause an infection. So yes, it can affect the immune system. And usually when you are talking about people who are immunocompromised, CKD, you'd have to consider them as well. Okay.
Okay, sir. Thank you.
You're welcome. So investigations, what do we do for the patient? So our basic urine RE, we want to look out for proteins in the urine and blood in the urine, because you remember our etiology, we said something about diseases of the glomerulus and all that. So you need to take a look at that. A urine culture and sensitivity results will tell you if there's an infection. It will point to the direction of the antibiotic to use. B and creatinine level, very essential because it tells you the level of the urea, creatinine, and electrolytes. A uric acid test, I didn't put that here, so kindly recall that. If you want to know, because remember we said it takes about 50% of the nephrons to be destroyed before you have an impairment of your BE and creatinine, but your uric acid levels will go up early, very fast when you have an impairment. So it's one of the things we do, especially on my ward where we take care of obstetric patients. If we're suspecting they have pregnancy-induced hypertension and we are thinking maybe there's a preeclampsia and we want to assess the state of the kidney, even though we request for BU inquiry, we also add a uric acid because the uric acid levels is what is going to point us to what we are basically looking for. When you have a kidney problem, your uric acid will start going up faster than your BE inquiry. Full blood count, HB, very essential. We've talked about anemia. We can't overemphasize. We've talked about infection, so WBC is very, very, very essential. Electrophoresis, sometimes, of course, you remember what we're talking about in terms of the etiology. We said sickle cell and all that, so HB electrophoresis would help you make the diagnosis. You can do an immunology screen where you are looking out for the cause of the disease, so autoantibody screening, complement screening, Hep B, Hep C, HIV, all of this can lead to a chronic kidney disease. Imaging study, very, very essential. You can do an ultrasound, you take a look at how the kidney is looking. And you remember last time I said a kidney has a cortex and a medulla. When you are dealing with a chronic kidney disease, one of the things that will differentiate it from your acute kidney injury is that when you scan an acute kidney injury, you realize that the cortex and the medulla is clearly, you can define it, clearly definable. But when you scan a chronic kidney disease, you can't tell that there's some sort of alteration there. So we say that there's a loss of corticomedullary differentiation. Usually when you see a word like that on ultrasonography, there was loss of corticomedullary differentiation of the kidneys bilaterally. Then it tells you that you couldn't differentiate the cortex from the medulla, and that tells you that clearly the patient has some form of CKD. You can do a renal biopsy for histopathology. That could also spare you onto making your diagnosis. Okay. So management, we've been talking about a lot of management for kidney disease. You realize that this is not different. It follows the same pattern, okay? So in terms of management, what you're going to do is your focus is on protecting the kidneys. We are saying that you can't do anything to halt a chronic kidney disease. You can't. And that is what we should all know as we are young now. We should take good care of ourselves. Whenever we say don't eat late, whenever we say exercise, don't drink, don't smoke. These are some of the reasons why. Because once you develop a chronic kidney disease, you can't stop it, you see. And you'd have gone to school for so long and you are now working and you are making some good cash. You bought your dream car, maybe a Mercedes or a Range, and then your son or your daughter is driving you in your dream car to the hospital to manage your CKD for you. I mean, we wouldn't want that. So lifestyle changes is very, very essential. In terms of prevention, we need to advise our clients or our patients. Okay, very, very essential. Then in terms of management, renal protection, so you need to, you are looking at protecting the kidneys from further damage. So you are controlling your blood pressure, you are controlling your sugar levels and all that. And usually we say the goal is to keep the blood pressure below 120/80. Okay. And if there's proteinuria, the proteinuria should be less than 0.3 grams. So you can see that for patients who have CKD, like when you're looking at the general population, we'll say, oh, BP 140/90. So when you're managing, your BP should be below 140/90. But when the patient has a chronic kidney disease, you are not looking at 140/90 because even that still has a problem when it comes to the kidney. So your goal is to keep the blood pressures below 120/80. Okay. Then once there's proteinuria, you give your ACE inhibitors or your ARBs. Example of ACE inhibitors, lisinopril, ramipril, and all that, ARB, losartan, valsartan, you give it. And you remember our previous lecture, we said that this medication prevents proteinuria. It has an anti-proteinuric effect, so it prevents proteinuria. However, we also said, and I showed you a diagram with that description, that because these ARBs, ACE inhibitors, are able to affect or they cause like a sort of dilatation of the efferent arterioles, it decreases the pressure in the glomerulus, and then it affects the EGFR. So usually the patient has issues with the blood vessel like a renovascular disease, you wouldn't want to give your ACE inhibitor or your ARB because already this patient has issues with blood flow to the kidneys, and they are also going to cause efferent arterial dilatation. It will make it worse, so you don't give. Okay. So if you listen to the previous lecture, there was a schematic diagram which I explained so you take a look at that again. You give your diuretic, okay, and then you make sure that you are preventing hyperkalemia. So you want to get rid of this excess fluid and potassium. You can add a calcium channel blocker like an amlodipine if the goal of the BP is not achieved. We are saying that there's also issues with lipid metabolism, so you put them on statins. They need to stop smoking. You need to manage their diabetes properly. Your HbA1c should be below 7%, okay? And then you don't say they should stop eating proteins. No, they should eat a normal protein diet. So basically the management is more supportive. It's not curative. If you want to go curative, then you'd have to look at what we call a renal replacement therapy, okay, which I've told you about renal replacement therapy in the previous lecture. You do a dialysis for the patient, which is like it's taking over the kidneys function basically, but dialysis is quite expensive. Your patient is going to be on it about 2 to 3 times in a week. It comes with also all sorts of, its issues and all that apart from cost. Can do a renal transplant, which is also expensive, but it also comes with taking a lot of immunosuppressive medications after the transplant. So you can see that there are management protocols, but they have their own side effects. And so you have to consider that in terms of management. When you are managing a patient with CKD and anemia, because we are saying that the low HB is due to the erythropoietin and other things, you can actually give your patient recombinant human erythropoietin, what we call EPO, 50 units per kg 3 times a week. Okay, and the target is to keep the HB about 11 to 12. If the HB is low, below 7, you need to transfuse your patient. But of course, you need to keep in mind that this patient might be edematous and might be having a pulmonary edema. So you need to make sure you are giving enough Lasix as pre-medication to just get rid of the excess fluid, and then you transfuse your patient. So basically, it's a very huge topic, but as I say, I always try to make it easier, put it together. Once you read through the slides, you listen to the audio or you watch the video, and then you look at some files online. It should really influence your practice in a positive way, okay? So let me take your questions since time is a little bit fast spent. I think there was a hand up, if I could remember. I'll take that question. I'll take other questions, yes, and then we can close.
I was the one.
Yes, please. Let's take your question.
Yes, please. I would like to ask, with the investigations, is it possible because of the renal osteodystrophy, will it be possible?
Yes, so it's not a bad thing, but then if this renal osteodystrophy is a general thing, there's bone pain everywhere, you wouldn't want to subject your patient to X-ray of your upper limb, lower limb, pelvis, everything. You wouldn't want to do that. The X-ray will come in if there's something more beyond the renal osteodystrophy, because we know that the reason why this patient has a bone pain in CKD, we know the reason, we know the pathophysiology is because of increased calcium resorption. So why do you want to do an X-ray? You only want to do an X-ray if there's something else. Maybe this bone pain and weakness of the bone has caused the fracture of the bone.
Okay.
Or something called a pathological fracture. So the patient says that, oh, I used to have pain, but now I think the pain in my hip is so severe. So that means you're going to X-ray the hip and you're going to take a look at the hip to see. And it won't be surprising that you might find a pathological fracture over there. Do you understand?
Yes, please.
Yes, yes.
Thank you.
You're welcome, sir.
Hello, sir.
Yes, please.
Yeah, please. My question is not about CKD, it's about peptic ulcer.
Yes.
Please, I want to know if a patient results H. pylori show positive, and then
Yeah.
the Salmonella typhoid also positive. Are you going to
Yeah.
combine the two?
Okay.
Since the peptic ulcer will go for triple therapy, are you going to add the typhoid to it at the same time?
Yeah. Okay, that's a good question. I got a call from a colleague I worked with. I think 2 weeks ago, I had a similar thing. Sent me labs of a young lady who has H. pylori positive and then without test positive. It depends. Your management is dependent on the symptoms at that time. Why am I saying that? You can have a patient. We have so many patients walking around with, they'll say without positive, so many of them. But then the question is, how specific is Wedal in diagnosing typhoid? Wedal is not specific in diagnosing typhoid. Other infections can lead to your Wedal titers going up. And even for all you know, your H. pylori infection could be the cause of the reason why your Wedal titers are up. You understand?
Okay.
So Wedal is not specific. So if you think that the symptoms the patient is showing, I think the patient has typhoid, which probably the patient has fever, headaches, chills, like something like this malaria-like symptoms. You don't stop there at doing a Wedal test to confirm. Right now, they have the typhoid IgG, IgM that you can do to combine to your Wedal. And if IgM is positive, then it tells you that probably the patient has been exposed and the patient has some form of recent infection and is making antibodies. If IgG is positive and IgM is positive, then it tells you that the patient has a past infection. IgG will usually be chronic infection. The patient has some past infection and now has been exposed again. Okay. If IgG is positive, IgM is negative, then it means the patient has a past infection, but at the moment, the patient doesn't have any infection at all. So that will guide you to being objective about your typhoid. But then again, the gold standard for diagnosing typhoid is culture and sensitivity. The books will tell you that a bone marrow culture aspirating a bone marrow, doing a culture and sensitivity is the gold standard. But of course, you can also do a stool culture and sensitivity, a blood culture and sensitivity, a urine culture and sensitivity to help you in the diagnosis of your typhoid, even though the bone marrow is more sensitive, followed by blood, and then followed by stool and then urine. You get it? So if you are not sure, you can back your diagnosis of your typhoid. I'm saying this because in my opinion, I'll look at the patient, and if at that point the patient is presenting to me H. pylori positive, because I'm sure the reason why I asked the patient to go and do the H. pylori was because the patient had some form of epigastric discomfort. I will start my triple therapy first, whilst I await confirmation for the typhoid before I institute. I won't put the patient on triple therapy and add Cipro to the medication. Are you okay?
Yes, sir. Thank you very much.
Yes, you're welcome. Okay, so God willing, I have a big program coming up next weekend, so we'll be unable to meet, and even on Wednesday, it will be a challenge. So I'll let Nick and Thomas discuss with the class if you'll be available for me on Monday evening and Tuesday evening. We can move to a next system, and then we can discuss. Maybe we can use that to talk about rheumatology, and then we know we are done with those systems on the 2 days, or we can even look at endocrine on the 2 days. So Nick and Thomas, I'll be standing by for your feedback. Please discuss with the team and let me know if Monday and Tuesday would be okay for you. Otherwise, we would have no lectures next week until the other week, but we also don't have time. So let's decide and then let me know. Okay. So.
No, please, what's the big program? Are we invited?
No, it's something a bit.
No, please.
Don't worry. When I'm going to deliver my speech one day on a high podium, or I'm going to deliver my presentation for a big academic certificate, I invite all of you. Don't worry. We haven't gotten.
Wish you all the best.
Thank you.
That day they will come all day.
Okay, enjoy your evenings, and then I'll be waiting for the feedback and class reps by the close of tomorrow so we can plan. Okay, good night.
Good night.
Night.
Sounds lived up.
Okay.
Night, Paul.